Welcome to the deep dive. We're all about cutting through the noise, getting straight to the essential, maybe surprising facts you need. Today, we're plunging into something that affects, well, a huge number of men globally. Male hair growth and loss, often just seen as, cosmetic. But here's the thing, right off the bat, that receding hairline, it's not just about looks, it's actually a complex medical thing with real psychological impacts. And this is key, it has documented links to your broader health. We're talking 30 to 50% of men by age 50. So our mission today is simple. Break this down, give you the shortcut to being properly informed, facts, practical tips, the whole deal. We're drawing straight from a clinical guide on managing and even reversing hair loss. Solid stuff.
Exactly. And what's really eye-opening is that male androgenetic alopecia, MAA, male pattern baldness, it's increasingly seen as a potential flag for other things like cardiovascular disease, BPH, that's benign prostatic hyperplasia, even some cancers. So this deep dive, it isn't just vanity. It's about understanding a basic biological process and how it connects to your overall health. Really changes the perspective, doesn't it?
Wow. Yeah, that totally reframes it. Aesthetics connected to heart health, cancer.
Yeah.
It's probably news to a lot of people listening. Okay, so to get why hair goes, we first need to get how it grows. Think of your scalp, maybe 100,000 hair follicles. Each one is like its own little independent garden, right?
Right.
With its own cycle. And that cycle has three main phases. First up is anagen. That's the growth phase. This is when hair is actually growing. For scalp hair, it can last, 2 to 6 years, something like that.
Yeah, typically 2 to 6 years. And for most healthy people, about 85 to 90% of their hair is in this active growth phase at any one time. Then you hit catagen, the transition phase, very short, maybe just a few weeks. The follicle basically says, okay, break time. It shrinks, detaches from the blood supply. And finally, telogen, the resting phase, lasts a few months. The hair just sits there dormant until a new hair starts growing underneath and pushes it out. You might also hear about canogen, that's the little gap between shedding and new growth, and exogen, which is the actual shedding process, losing 50 to 100 hairs a day, totally normal, part of the cycle.
So finding a few in the comb isn't necessarily cause for alarm. It's just redecorating, like you said.
Yeah.
Okay, so if that's the normal garden cycle, what happens when it starts failing for so many men?
Well, the main reason, globally, is male androgenetic alopecia, MAA, male pattern baldness. It follows that classic pattern, receding temples, thinning crown, maybe the mid-frontal area too. And here's a really crucial point, something I really want you to grasp. MAA isn't actually a disease state. It's not like an illness you can just cure. It's more like a genetically programmed physiological process. Think of it like a pathway built into some people's biology. And it's triggered by normal hormone levels, not some crazy excess. So when we talk about treatments, we're talking about intervening in that biological process, not, curing a disease. It's a different mindset.
Right, so it's something your body's kind of designed to do if you have the right genetics set up. And those genetics are huge, right? Like 80% of the picture.
Absolutely. Twin studies really confirm that 80% hereditary factor. And it's polygenic, multiple genes from both sides of the family. That's why you might not look exactly like your dad in terms of hair loss. But the big one, the key gene, is the androgen receptor gene, the AR gene. It's on the X chromosome.
Ah, so that's why people say it comes from your mother's side. Because men get their X chromosome from their mom.
Exactly. And there's a specific version, a variant of that AR gene found in over 92% of bald men. If you've got it, your chances of MAA jump to about 70%. These genes basically make your hair follicles extra sensitive to certain hormones.
So genetics loads the gun.
And hormones pull the trigger.
Yeah.
And the key hormone isn't testosterone itself, surprisingly to many. It's dihydrotestosterone, DHT, a much more potent version. Inside the hair follicle, there's an enzyme called 5-alpha reductase, the type 2 kind, specifically. It acts like a little factory, converting testosterone into this powerful DHT.
Got it. So DHT is the main chemical troublemaker here. And in guys with MAA, the balding spots have more DHT floating around in those super sensitive receptors we just talked about. A hyperandrogenic milieu, as the experts call it.
That's right. A supercharged male hormone environment right where the hair is thinning. And when DHT binds to those receptors, it kicks off, basically 3 interconnected problems. First, follicular miniaturization. This is the absolute hallmark sign under a microscope. Your thick, healthy terminal hairs get replaced cycle by cycle with thinner, weaker, almost invisible vellus-like hairs. The control center, the dermal papilla, shrinks like a big tree slowly turning into a tiny bonsai.
Okay, shrinking follicles. What else?
Second, the hair cycle gets messed up. The anagen, the growth phase, gets shorter and shorter with each cycle, but the resting telogen phase stays the same or even gets longer, so the ratio is all wrong. Eventually, that growth phase gets so short the hair barely makes it to the skin surface before it's kicked out. And third, there's this low-grade, persistent microscopic inflammation around the follicle. We used to think it was just a side effect, but now evidence suggests it actually helps destroy the follicle over time.
So DHT attacks from 3 angles. Shrinks the factory, speeds up the burnout, and adds inflammation. That makes sense. But let's circle back to that really important point you made right at the start about the broader health connection. You said early balding could be a sign of other issues.
Yeah, absolutely. Looking at the big picture, studies show that severe early onset balding might be linked to a higher risk of things like high blood pressure, high cholesterol, heart attacks, insulin resistance, BPH, even prostate cancer. It means your hair loss might be more than cosmetic. It could be an early warning signal from your body, a reason to maybe get a more thorough health checkup.
That's really important context. Okay, so MAA is the main thing, but hair loss isn't always that, right? What are some other causes people should be aware of?
Definitely. Sometimes it's telogen effluvium, which is stress-induced shedding. Think major surgery, a bad illness, intense grief, even childbirth. You get this sudden diffuse shedding, usually a couple of months after the stressor.
Because of stress hormones like cortisol.
Exactly. Cortisol surge disrupts the cycle. The good news is it's usually temporary. Hair tends to grow back in 6 to 9 months once the stressor is gone. Then you have autoimmune conditions. Alopecia areata is the main one. Your immune system basically attacks the hair follicles by mistake, causes these sudden round bald patches. Can happen anywhere, body hair too. It's unpredictable. Sometimes it regrows, sometimes it doesn't.
Okay, what else?
Other possibilities include thyroid problems, lupus, scalp infections like ringworm tinea capitis, certain medications, obviously chemotherapy, but also some arthritis drugs. And nutritional deficiencies are a big one.
Like iron or zinc.
Iron and zinc are common culprits, yes. Some vitamins, too. Oh, and don't forget traction alopecia. That's hair loss from hairstyles that constantly pull too tight on the hair, like tight braids or ponytails over a long time.
Right. Which all just goes to show you really need a proper diagnosis before you start treating anything. Don't just assume it's male pattern baldness.
Absolutely critical first step.
Okay, so assuming you do get that diagnosis of androgenetic alopecia, what are the main medical treatments? You mentioned 2 cornerstones earlier.
Yes, finasteride and minoxidil. They've been the mainstays for a long time. And crucially, they work very differently, which means they can be used together effectively.
Let's start with finasteride. Alopecia is the brand name many people know. How does that one work?
Finasteride targets DHT right at the source. It's a 5-alpha reductase inhibitor. Specifically, it blocks that type 2 and 3 enzyme we talked about, the one that converts testosterone into DHT inside the hair follicle. Just a 1 milligram pill taken daily. It cuts down DHT levels in your blood by about 70% and in your scalp by over 60%. Pretty significant reduction.
And does it work? What's the evidence look like?
The evidence is pretty strong. Clinical trials showed about 83% of men on finasteride stopped further hair loss, compared to only 28% on placebo. One study even measured an average gain of 138 hairs in a small 1-inch circle area. And it lasts. Studies show the effects hold up over 5, even 10 years. There's a 10-year Japanese study really impressive. 91.5% showed improvement, and 99.1% prevented further loss.
Yeah. How quickly do you see results?
Usually starts becoming noticeable around 3 to 6 months. Peak effects are typically seen at the 1 to 2 year mark.
But it's a treatment, not a cure, right?
Yeah.
You have to keep taking it.
That's the absolute key message. Continuous use is essential. If you stop taking finasteride, unfortunately, any hair you gained or kept will likely be lost within about a year. The underlying process just kicks back in.
Okay, let's talk side effects and risks.
Yeah.
'Cause that's always a concern with finasteride. What should people know?
Right. It's important to have a balanced view. The most discussed side effects are sexual ones. In trials, these were reported by a small percentage, typically around 2 to 4% of men. Things like decreased libido, erectile dysfunction, or less ejaculate volume. Often these might decrease over time with continued use, or they usually resolve if you stop the medication.
Are there non-sexual side effects too?
Yes. Less commonly, things like gynecomastia, that's breast tenderness or enlargement skin rashes, maybe some dizziness. There's also ongoing discussion and some evidence linking it to depression, and very rarely suicidal thoughts. That needs careful consideration with your doctor.
You also mentioned something about prostate cancer risk and PSA tests earlier. That sounds quite serious. Can you clarify that?
Yes, good point. Finasteride lowers your PSA levels. PSA is a marker used in prostate cancer screening. So your doctor absolutely needs to know you're taking it to interpret those test results correctly. They have to adjust for the effect. Now, regarding risk, It's a bit nuanced. Finasteride actually reduces the overall risk of developing prostate cancer by about 25%. However, some studies suggested a small increased risk of getting a high-grade, more aggressive form of prostate cancer if you do get it. It's something doctors weigh against individual risk factors.
And definitely not for pregnant women.
Absolutely not. Strict contraindication. It can cause birth defects in a male fetus if a pregnant woman is exposed.
And what about this post-finasteride syndrome, PFS? You hear about that sometimes.
Yes, PFS is a controversial area. It refers to reports of persistent side effects, sexual, neurological, physical, that continue even after stopping the drug. It's rare, the mechanisms aren't fully understood, and it's still being researched.
And topical finasteride, is that safer?
Well, topical finasteride isn't FDA approved. It's usually compounded. The idea is less systemic absorption, but it can still get absorbed into your system. So while potentially reducing side effects for some, it doesn't eliminate the risks entirely. It carries similar warnings. Okay, let's shift gears to minoxidil. Rogaine. That one has a different story, right? Started as a blood pressure drug.
Yeah, fascinating origin. Hair growth was purely an accidental discovery, a side effect. Its main job now, for hair loss, is revitalizing the follicle. Mechanism-wise, it's known as a potassium channel opener and a potent vasodilator. So it basically increases blood flow to the scalp, more oxygen, more nutrients getting to those follicles.
And here's the interesting part, the aha moment for many users. It seems to work by shortening that resting telogen phase and pushing hairs into the anagen or growth phase more quickly.
So that explains the initial shedding some people get. It's clearing out the old to make way for the new.
Exactly. It's counterintuitive, but often a sign it's starting to work. It also seems to stimulate growth factors like VEGF, which helps build new blood vessels around the follicle. Essentially, it's waking up dormant follicles and boosting the local environment.
Like a wake-up call for the scalp. Okay, so how do you use it, and how well does it work compared to finasteride?
It's available over the counter, usually as a topical liquid or foam, 2% or 5% strength, applied twice a day. There's also low-dose oral minoxidil, but that's off-label and needs a prescription and careful monitoring due to higher risks. Efficacy-wise, it definitely slows loss and can regrow some hair. You typically need about 4 to 6 months to see visible results. And like finasteride, if you stop, the benefits fade. The 5% topical is generally considered more effective than the 2%.
And side effects, are they different for topical versus oral?
Very different. With the topical stuff, side effects are usually local. Scalp irritation, itching, maybe some redness. Sometimes that's due to the vehicle, like propylene glycol, and switching to a foam version can help. You can also sometimes get hypertrichosis, unwanted hair growth on the face or forehead if the product drips. Systemic side effects from topical are rare because not much gets absorbed.
But the oral version is different.
Yes, oral minoxidil is systemic, so the potential side effects are more significant because it's dilating blood vessels everywhere. Things like fluid retention, edema, maybe a rapid heartbeat, dizziness, headaches. Very rarely, serious things like pericardial effusion fluid around the heart can occur. That's why oral requires medical supervision.
Okay, so finasteride blocks DHT, minoxidil stimulates the follicle. Since they work differently, does using them together make sense?
Absolutely. That's often considered the gold standard for medical management. Think of finasteride as defense stopping the DHT attack and minoxidil as offense boosting growth. Because their mechanisms are different, they're synergistic, they work better together than either one does alone.
Is there data on that?
Yeah, there is. One key study showed 94% of men using both had improvement, compared to about 80% with finasteride only, and around 59% with minoxidil only. So that combination gives you the best shot medically.
A real 1-2 punch. Okay, but what if the loss is more advanced or someone wants a more permanent fix? That's where surgery comes in, right?
Exactly. Surgical hair restoration is for more significant loss, or when medical therapy isn't enough. It's not creating new hair, it's moving your existing DHT-resistant hair. Hair follicles from the back and sides of your scalp are genetically resistant to DHT. The surgery basically relocates those healthy follicles to the balding areas on top. And because they keep their genetic resistance, the results are permanent.
And there are two main ways they do this, FUT and FUE.
That's right. FUT, or follicular unit transplantation, is the older strip method. A thin strip of scalp tissue is removed from the donal area, usually the back of the head. That strip is then carefully dissected under microscopes into individual follicular units, tiny bundles of 1 to 4 hairs. Then, tiny slits or holes are made in the balding area, and these units are meticulously placed, matching natural angle and direction.
Okay, and FUE. That's different how.
FUE, follicular unit extraction, is more recent and less invasive in some ways. Instead of a strip, the surgeon uses a tiny circular punch tool to remove individual follicular units directly from the scalp one by one. This avoids the long, linear scar of FUT. Instead, you get tiny little dot scars scattered across the donor area, which are much less noticeable, especially with short haircuts.
So comparing FUT and FUE, what are the key trade-offs for someone considering surgery, besides the scar?
Well, first off, surgeon skill is absolutely critical for both methods to get good results. But yeah, key differences. FUT is generally more invasive up front, involves stitches. FUE is less invasive per extraction, but the overall procedure time might be longer. Scarring is a big one, linear for FUT, dots for FUE. Recovery tends to be a bit quicker with FUE, less initial discomfort. Cost is another factor. FUE is usually more expensive per graft because it's more labor-intensive for the surgeon.
And the costs can be substantial, right? You mentioned ranges earlier.
They can be. In the U.S., easily $4,000 to $15,000 or even more, depending on the extent. In a place like Mumbai, maybe starting around $30,000 for a smaller FUT case, going up to $2,000 or more for larger FUE procedures. It's a real investment.
Definitely. So after the surgery, what's the timeline and what are realistic expectations?
Okay, timeline. Right after surgery, the transplanted hairs will actually shed. That's normal, called shock loss. Don't panic. New, permanent growth starts peeking through around 3 to 4 months. It becomes more noticeable by 6 to 9 months, and you typically see the full final result around 12 to 15 months post-op. It takes patience.
And the crucial point about keeping the rest of your hair.
Yes, this is vital. The transplanted hairs are permanent, but your native hair, the non-transplanted hair in the surrounding areas, is still susceptible to DHT and will likely continue to thin over time if you have MAA. That's why lifelong medical therapy, usually finasteride, maybe minoxidil too, is often essential after a transplant. It helps you hold on to that native hair, maintain the overall density, and prevent the need for more surgery later. It's about protecting your investment and getting the best long-term look. Surgery restores, medication preserves.
That makes total sense. Okay, so we've hit the biology, the big medical guns, the surgery. But what about the foundations? Diet, lifestyle, stress? Do those actually matter for genetic hair loss?
They matter hugely. While they won't cure genetic baldness on their own, they are absolutely crucial for maximizing how well any treatment works and just for overall hair health. Think of them as the soil quality for your hair garden.
Let's talk nutrition then. What does hair need?
Hair is incredibly metabolically active. It needs fuel. The hair shaft itself is almost entirely protein keratin, so getting enough protein is non-negotiable. Your body needs those amino acid building blocks like L-lysine to make keratin. If you're deficient, you can get shedding, brittle hair.
How much protein are we talking?
General recommendation is about 0.8 to 1.0 grams per kilogram of your body weight daily. So for a 70-kilogram guy, that's roughly 56 to 70 grams. Lean meats, fish, eggs, dairy, beans, tofu, nuts, seeds, lots of good sources. But more isn't better. Getting excess protein doesn't help your hair. Balance is key.
Okay, protein is the main building block. What about smaller nutrients, vitamins, minerals?
Absolutely critical. Iron deficiency is a surprisingly common cause of hair shedding, even if you're not fully anemic. Iron helps carry oxygen to the follicles. Zinc is vital for hair tissue growth and repair and keeps the oil glands around the follicles working right. Zinc deficiency is clearly linked to hair loss. Vitamin D low levels are associated with alopecia. It seems to play a role in creating new follicles, though we're still learning exactly how.
What about biotin? That's always marketed for hair.
Yeah, biotin, a B vitamin, is involved in keratin infrastructure. But true deficiency is actually very rare. And for people with normal levels, there's very little solid evidence that taking extra biotin supplements does much for hair growth. It's mostly hype unless you're deficient. Vitamin C is important too. It's an antioxidant, helps build collagen, and crucially helps you absorb iron from plant-based foods.
But you can overdo supplements, right? Can taking too much actually cause hair loss?
Yes. This is a really important warning. Over-supplementing certain nutrients can definitely cause hair loss or make it worse. Be especially careful with high doses of vitamin A, vitamin E, and selenium. It's all about balance. Don't just randomly pop pills. Ideally, get tested to see if you actually have a deficiency before you start supplementing heavily.
Good advice. Okay, what about stress? We touched on telogen effluvium, but does everyday chronic stress affect male pattern baldness?
The mind-hair connection is real. We know severe stress triggers that diffuse shedding, telogen effluvium. Chronic stress keeps cortisol levels elevated, which can disrupt the hair cycle long-term and potentially worsen underlying MAA, though the direct link is harder to pin down than for TE. Managing stress is key. Things with good evidence include mindfulness, meditation, yoga, tai chi. Getting enough quality sleep 7 to 9 hours is huge for hormone regulation and stress resilience. And don't underestimate social support or professional help if you need it.
It's all connected, isn't it? Bad sleep, more stress, maybe you eat worse.
Exactly. It becomes a vicious cycle that isn't doing your hair any favors.
And exercise. Does that help or hurt?
Exercise is generally great. Cardio boosts circulation to the scalp, more blood flow, oxygen, nutrients. It's also a fantastic stress buster, lowers cortisol, releases endorphins. Moderate exercise helps balance hormones too. But there's a caveat. Chronic, super high intensity, excessive exercise can actually act as a physical stressor on the body. This could potentially raise cortisol and maybe even DHT levels in some individuals, which theoretically could worsen hair loss if you're already prone.
So like, training for ultramarathons might not be the best idea for your hair.
Potentially, yes.
Yeah.
The key is finding a balanced, sustainable routine. Moderate, regular exercise is definitely beneficial. Extreme chronic exertion might tip the scales the wrong way for some.
Okay, that makes sense. Now let's get into the murky world of other treatments. There are tons of shampoos, oil, supplements out there claiming to help. How do we sort through the hype? What actually has some science behind it, even if it's not as strong as finasteride or minoxidil?
That's a great question. It's crucial to evaluate these critically. Let's look at some popular ones.
What about ketoconazole shampoo, like Nizoral? People use it for dandruff, but sometimes for hair loss too.
Right. Its main job is antifungal, great for dandruff or seborrheic dermatitis. But for hair loss, it seems to help in two ways. One, it just creates a healthier scalp environment, reducing inflammation. Two, it actually has mild anti-androgenic effects. It seems to be a weak inhibitor of 5-alpha reductase locally in the scalp, cutting down DHT a bit.
Is the evidence any good?
Reasonably good, actually, for an adjunctive therapy, meaning something used alongside the main treatments. Some studies found using it 2-3 times a week was comparable to using 2% minoxidil for improving hair density and thickness. So it's a worthwhile addition for many.
Okay, interesting. What about all those caffeine shampoos and serums?
Caffeine is interesting. Lab studies in vitro show it can counteract testosterone's negative effects on hair follicles, prolong the growth phase, and stimulate the main cell's keratinocytes, and it penetrates the follicle quickly.
But does it work on actual human heads?
The human evidence is promising, but still a bit shaky. Many studies aren't great quality. However, one better study did find that a 0.2% topical caffeine solution performed just as well as 5% minoxidil in improving the ratio of growing to resting hairs. So it might offer some benefit, but it's definitely not considered a first-line standalone treatment like minoxidil or finasteride, maybe a supporting player.
Got it. Let's move to botanicals. Rosemary oil seems popular lately. Any truth to that?
Surprisingly, yes. Rosemary oil has antioxidant and anti-inflammatory properties. It seems to improve circulation in the scalp. And here's the interesting part. It might actually inhibit 5-alpha reductase, like finasteride, but weaker, and also boost VDGF, like minoxidil. So multiple potential mechanisms.
Wow. Is there solid proof?
There's one key human study from 2015, a randomized controlled trial. It compared rosemary oil directly to 2% minoxidil for 6 months. The finding: rosemary oil was just as effective as the minoxidil at increasing hair counts. Plus, users reported less scalp itching with the rosemary oil.
That's pretty impressive for natural oil.
It is. Now, it's just one study. It needs more research to confirm, but it's definitely one of the more compelling natural options based on current evidence. You'd want to dilute it in a carrier oil like jojoba or coconut before applying it, though. Don't put it on straight.
Okay. What about peppermint oil? Hear about that one too.
Peppermint oil contains menthol, which is a vasodilator. It increases blood flow. There are some animal studies, mainly in mice, suggesting it can kickstart the anagen growth phase early. One mouse study even showed it outperformed 3% minoxidil.
But there are no human clinical trials for peppermint oil and hair loss. So, while interesting in mice, we can't say if it works for people. It's speculative at this point.
Right. Mice results don't always translate. Okay, saw palmetto. That's often touted as a natural DHT blocker like finasteride. Does it work? That's the theory, that it inhibits 5-alpha reductase. The evidence in humans is, well, it's limited and often conflicting. Some reviews sound positive, but when you look at direct comparisons, it doesn't hold up as well. There was one head-to-head study comparing it to finasteride. Finasteride showed about 68% improvement, while saw palmetto only showed 38%. So it seems to be significantly less effective than the pharmaceutical option. Maybe some mild benefit, but likely not a replacement.
So a weaker alternative at best. And briefly, what about peptides? Things like copper peptides. Is that the next big thing?
Peptides are short chains of amino acids. They act like signaling molecules. GHKQ, or copper peptide, is the most studied for hair. The theory is it helps blood vessel formation, reduces inflammation, might inhibit DHT a bit, and stimulates follicle cells. But the evidence is still very early stage. Mostly lab studies or very small human pilot studies. We're lacking the large, robust, randomized controlled trials needed to really prove effectiveness and safety. So for now, peptides remain experimental, kind of on the horizon.
Okay, so that's a good overview of what has some evidence versus what's still mostly theory. After taking all this in the biology, the meds, surgery, lifestyle alternatives, what's the actual path forward for someone listening who's worried about their hair?
The absolute number one critical first step: get an expert diagnosis. Don't guess. See a board-certified dermatologist or a qualified trichologist who specializes in hair loss.
Why is that so crucial?
Because, as we discussed, hair loss can have many causes. It might not be MAA, it could be telogen effluvium, alopecia areata, a nutritional deficiency, a thyroid issue. You need the right diagnosis to get the right treatment. Treating the wrong thing won't help and could delay finding the real cause. Plus, sometimes hair loss can signal an underlying health problem that needs attention.
Right, so what happens at that first consultation? What should you expect?
Expect a pretty thorough evaluation. They'll take a detailed medical history, ask about your family history of hair loss. They'll do a physical exam of your scalp, often using a special magnifying scope called a trichoscope, to get a close-up look at the hair follicles and scalp condition. They might do a simple hair pull test to see how much hair is shedding easily. They'll likely order blood tests, checking thyroid, iron levels, specifically ferritin, vitamin D, maybe other hormones depending on your history.
Sometimes a biopsy?
If the diagnosis isn't clear from the exam and history, yes, they might take a tiny punch biopsy from the scalp for analysis. Once they have all that information, they can confirm the diagnosis and work with you to create a personalized treatment plan.
Okay, let's make this really concrete. Say someone listening is in Mumbai. How would they find help, and what kind of costs are we talking about there, just as an example?
Great idea. Mumbai has a very active market for hair loss treatments. You have major hospitals with dermatology departments like Manavati Max, with experienced doctors like Dr. Vandana Punjabi or Dr. Ann Nahar. Then you have specialized chains like Richfield or Berkowitz. And many highly regarded individual dermatologists and trichologists and private practice people like Dr. Rinki Kapoor, Dr. Batul Patel, Dr. Rika Yadav, among others. Using platforms like Practo or JustStyle can help you find specialists, read reviews, and book appointments.
And the cost in a place like Mumbai, what's realistic?
Costs vary quite a bit, of course. An initial consultation might be anywhere from $500 to maybe $2,000. If treatments like PRP platelet-rich plasma are recommended, each session could be $5,000 to $15,000. For transplants, the strip method, FUT, might range from $30 to $100 per graft. FUE is usually pricier, maybe $50 to $150 or even more per graft.
So for a decent-sized transplant, say 1,500 grafts,
you could be looking at maybe $45,000 on the low end for FUT, up to potentially $1 million on $35,000 or more for high-end FUE. For a larger session, like 3,000 grafts, you could easily double that, maybe $90,000 to well over $3,000.
Wow, that's significant, and usually not covered by insurance, right?
Correct. Hair loss treatments, especially transplants, are typically considered cosmetic and aren't covered, so getting a detailed, personalized quote upfront is essential.
Okay, so you got the diagnosis, you understand the costs. How does a doctor actually put together a strategy? You mentioned frameworks earlier.
Yes, because the best approach is usually multi-pronged. It depends on the stage of hair loss and the patient's goals. So framework 1, early intervention or prevention. Maybe you're just starting to notice mild thinning or have a strong family history. The goal is preservation. Here, the core medical therapy would likely be oral finasteride to block DHT. You might add topical minoxidil as an adjunct, maybe ketoconazole shampoo. And absolutely crucial, nail down the healthy lifestyle factors: diet, stress, exercise.
Okay, what about moderate loss? More noticeable thinning?
Framework 2, moderate hair loss. The goal here is to halt the progression and ideally get some visible regrowth. This is where the combination therapy really shines. So the core medical approach would be both finasteride, likely oral, and topical minoxidil. Adjuncts like ketoconazole shampoo are still good. You might also consider therapies like PRP sessions to give an extra boost. And again, lifestyle optimization is non-negotiable.
And for advanced loss, where surgery is on the table?
Framework 3, advanced hair loss. Goal: restore coverage and then maintain it. Here, surgical hair restoration, FUT or FUE, becomes the primary therapy to repopulate those bald areas. But, and we really have to hammer this, home surgery needs support. Essential ongoing medical therapy is critical. That usually means a lifelong commitment to finasteride and often minoxidil as well after the transplant.
To protect the remaining native hair.
Exactly. The transplant fills the gaps, the medication stops the gaps from widening further. Without it, you risk the native hair thinning behind the transplant, which doesn't look natural and might mean needing more surgery later.
Right, that makes perfect sense. Okay, let's try and wrap this up. Key takeaways from this deep dive.
Well, first, remember, MAA is genetic and hormonal, DHT-driven. It's about long-term management, not a one-time cure.
Second, finasteride and minoxidil are the proven medical cornerstones, especially when used together. They have the best evidence for stopping loss and regrowing hair.
Third, surgery offers a permanent solution for advanced loss by relocating resistant hairs, but crucially, it needs ongoing medical therapy afterwards to maintain the overall look.
Fourth, don't underestimate the foundations. Diet, exercise, stress management. They support everything else.
And fifth, while some adjuncts like ketoconazole shampoo and maybe topical rosemary oil have some supporting evidence, be skeptical of miracle cures and evaluate alternatives critically based on human data.
So what's the final word, the most important message for someone navigating this?
It really comes down to this. The most successful approach is personalized, multi-pronged, and evidence-based. There's no single magic bullet that works for everyone. The journey has to start with getting that definitive diagnosis from a professional. That leads to a tailored plan combining the proven medical stuff, maybe some smart adjuncts, and definitely locking in those healthy lifestyle habits.
A holistic approach, really. Which brings us to a final thought for you to consider. We've seen how managing hair loss involves understanding your body's biology, not just applying products. So here's the provocative question. If the same biological pathways, the same hormones and genetic sensitivities, influence both hair loss and potentially other serious health conditions like heart disease or prostate issues, could paying closer attention to what's happening on your head actually be an early guide, a prompt towards being more proactive about your overall well-being, maybe long before other symptoms even appear? Something to think about. Thank you for taking this deep dive with us today.